My name is Todd Barron. I'm the Director of Advanced Therapeutic Endoscopy at the University of North Carolina, Chapel Hill, and I'm here with my fellow, Ted James, also from the University of North Carolina, Chapel Hill, and we're here to talk about our article, EUS-guided gastroenteric anastomosis as a bridge to the definitive treatment in benign gastric outlet obstruction. We began clinically approaching some patients with benign gastric outlet obstruction, particularly when it was complete gastric outlet obstruction where the patient needed more immediate decompression to allow us to then treat underlying benign diseases, or in some cases allow their benign disease to resolve spontaneously on its own. The latter include diseases such as severe acute pancreatitis, with or without pancreatic fluid collections that cause duodenal and or gastric obstruction from edema and extrinsic compression to the patient then having complete gastric outlet obstruction. Options in those patients are often with PEG tubes, with jejunal tubes, either separately or in combination, but they don't allow the patient to restore oral continuity and enjoy eating. In addition, they obviously have an external tube that they often have to place the suction at home, which is also very uncomfortable. We've also had patients who have had duodenal hematomas. We had 3 patients who had duodenal hematomas with complete gastric outlet obstruction that we then allowed, that resolution occurred after placement of the gastrojejunal anastomosis with subsequent removal.
So this study was a retrospective case series looking at all patients who underwent endoscopic ultrasound-directed gastroenteric anastomosis at our center during a 6-year period. We excluded patients who had malignant obstruction and those that didn't have sufficient post-procedural follow-up. And the study endpoints of interest primarily was rate of definitive surgery, so how many did have to go to surgery, and we looked at also rate of adverse events, clinical success, and technical success of the procedure.
So over the 6-year period, we used a variety of techniques to perform gastroenteric anastomoses, but more recently we've settled on a technique that we believe is very effective and reproducible and has been used in other centers as well. And basically what we do is we advance a guide wire beyond the ligament of Treitz. We then take either a 7 French or 10 French nasabiliary tube and advance that beyond the ligament of Treitz. The endoscope is withdrawn, leaving the tube in place. The tube is then hooked up to a water irrigation pedal that you use for standard endoscopy. We fill the irrigant, or the irrigant that we use is a mixture of saline, methylene blue, and dilute contrast. We then begin insufflating the small bowel. We then begin distending the small bowel with the irrigation pedal. The endoscope is re-advanced alongside the nasobiliary tube, and once we see a nice loop of small bowel, we ask our anesthesiology assistant to provide 1 milligram of glucagon in bolus form, and then we use the hot Axios or Axios with electric cautery device using pure cutting current to create the gastrojejunal anastomosis.
During the study period, 53 patients underwent an endoscopic ultrasound-directed gastroenteric anastomosis, and 22 of these were for benign disease, 9 of which were women. 4 patients had surgically altered anatomy, including 2 were with Roux-en-Y gastrojejunostomy, 1 with Billroth 1 and 1 with Billroth 2, and the most common ASA grade was 3. 6 of the patients were outpatients at the time of the procedure. With regards to the cause of the outlet obstruction, peptic strictures were seen in 5 patients, and anastomotic strictures in 4. 3 patients had duodenal hematoma. 1 patient had recurrent acute pancreatitis. 4 had chronic pancreatitis. Pancreatic pseudocyst caused obstruction of the duodenum in 1 patient, and walled-off necrosis was seen in 4 patients.
So we did experience adverse events in 19% of patients. These include bleeding from an ulcer related to the lambs. We had 1 lambs migrate after the gastric outlet obstruction resolved, and the lambs was stuck in the terminal ileum, could not be retrieved endoscopically. The patient went to surgery. We also had one patient where we did not notice at the time, but the lambs went through a portion of the colon. They had no immediate adverse event, but it was recognized on delayed fashion, as is often seen with the inadvertent percutaneous endoscopic gastrostomy tube placement, that indeed it went through a portion of the colon and created a fistula from the stomach to the colon. This patient, despite having benign disease, is a very, very poor operative candidate for repair, has end-stage renal disease and ascites, and we have managed it with placement of other esophageal self-expandable metal stents to bypass the fistula, and we're hoping that as he improves with onset of dialysis that he might be able to undergo repair of the anastomosis.
So in terms of outcomes, in our cohort, all 22 patients had technical success with stent placement in the stomach and into the small bowel, and were able to tolerate at least a full liquid diet. 5 patients developed recurrent gastric outlet obstruction while the LAMS was still in place, and this occurred a mean of 228 days after placement. 3 of these were due to stent occlusion from food residue and were managed with endoscopic clearance of the debris. Of note, one patient we had with pyloric stenosis secondary to NSAID abuse had recurrence of her gastric outlet obstruction when the stent became occluded by food. After clearing the stent, it was determined that despite multiple balloon dilations of the stricture, actually it was 3 in total, that the stricture was still present and that the gastroenteric anastomosis that we had formed was going to be her only means of antegrade enteral intake. And at that time, the decision was made jointly with surgery for her to go for operative management. In all but 3 of the patients, we've already taken out their LAMS, and after the goo has resolved, and they've been doing well. This occurred a mean of 270 days after the initial LAMS placement. 2 of these patients had LAMS exchanged in the setting of persistent goo because of ongoing plans to treat the outlet obstruction, and 1 has plans to leave it in place indefinitely due to complex surgical candidacy.
So I think there are several points worth making regarding our study. We certainly understand that this is still considered off-label, and we believe that randomized trials or prospective trials are really needed to find the optimal use of luminal closing stents in patients with benign disease for performing gastroenteric anastomoses. But there's no question in my mind that there is a certain patient population that would clearly benefit from this placement. I think the patients that are most likely to benefit are patients with complete gastric outlet obstruction with a process that we know will resolve if given enough time. So again, patients that have severe pancreatitis would be ideal patients because at some point they should resolve their gastric outlet obstruction. The stent can be removed. So I think selecting the patient population is certainly paramount. We also know that this should be performed by people that are very experienced in endoscopic ultrasound guided techniques, because the potential for adverse events and need for emergent surgery, especially if there's been a misdeployment in one side of the bowel or the other. The other thing we don't know is what is the ideal stent diet. That still is yet to be determined. Given that we've had patients with food residue occluding their stent, we know that patients have not been completely compliant. So far we have recommended to our patients that they ingest a stent diet that we use for esophageal stents and gastroduodenal stents, but often I think if patients are doing well and tolerating it, they then advance their diet on their own. Most of them actually do probably reasonably well, but some of them do not. And finally, there is also one other subset, and we have a couple patients that have surgically frozen abdomens from prior abdominal surgeries. We've had very aggressive surgeons say they would never operate on the patient, and the only way we could resolve their gastric outlet obstruction was use of a gastroenteric anastomosis. What we've done, at least on one occasion, is to offer them stent replacement. Our concern being that if we leave the stent in place indefinitely, the The integrity of the covering could go away, and therefore you're then left with a uncovered or partially covered stent with all its attendant problems, which include tissue ingrowth, tissue hyperplasia, obstruction, and inability to remove. So we've actually been replacing in at least one patient. We began every 6 months, and then at 6 months everything looked good with the stent, so we were doing once a year. And it's a simple endoscopy, remove the stent, you already have a fistula, and you can basically replace with another luminal opposing stent through that. So that is another option to manage some of these patients long term who may be very poor operative candidates or non-operative candidates. But once again, we think that the future for EUS-guided therapies in this regard should not be limited just to patients with malignant disease.